Thank you for joining again. My name is Ben Linville-Engler. I am the Industry and Certificate Director for MIT System Design and Management. And this is going to be a part 2 short recording to a webinar that I gave on February 8th for the Systems Thinking webinar series for MIT STM. Now, if you haven't had a chance to take a look at the first part of this webinar series, I recommend that you find that in our YouTube channel. It'll make a little bit more sense in the context of some of the references that I'll make as I go forward to highlight sort of the second half of the work that I've been doing on the COVID response here in Massachusetts and across the US. So I'm going to go ahead and share my screen and jump into this second part. And feel free to reach out with any questions that you may have. My email address is listed here, benle@mit.edu. But let's go ahead and just dive into this second part here. So if you remember, the webinar series is called Ecosystem Engineering, Mobilizing a Statewide Manufacturing Response to COVID-19. And through the effort that I went through in the first part of the webinar that really focused on the Massachusetts Manufacturing Emergency Response Team, we started to not only help manufacturers pivot to make PPE, but also started to help manufacturers pivot their operations to produce test supplies, things like NP swabs, but also viral transport media. And so that was really kind of our initial step into the testing side of the COVID response, which will make sense as I get into this next section. So this next part is going to focus on a group called the Massachusetts Testing, Tracing, and Supported Isolation Collaborative. It is a sort of a group of different stakeholders from across Massachusetts and elsewhere that we've connected with, but really anchors on the Harvard Global Health Institute, the Brown School of Public Health, the Harvard Edmund Sofra Center for Ethics, as well as a sub-team from the Massachusetts Manufacturing Emergency Response Team, and brings together a lot of the different stakeholders that we had identified across the ecosystem here, from clinical and health experts to different, in this case, test providers or research labs, etc. And so I connected with this group on May 2nd. If you remember, when we first looked at when the MERT formed was in March 20th. And so this was right after we kind of peaked for the first surge. And actually this connection came through Professor Danielle Allen at the Harvard Sofra Center for Ethics, where she's the director there, and she had been spending the time while we were working with the MERT on putting together a roadmap to pandemic resilience and really looking at outlining a plan for massively scaled testing, contact tracing, and supported isolation to really provide a pathway for us to get out of the pandemic and enable us to really decouple the health crisis from the economic crisis. And one of the really important things that happened early on with this group and the team at the Harvard Global Health Institute is that they were working to really converge on a number of metrics that really allowed us to understand the relative risk to COVID across the US. This was something that we didn't really have a great view on during the first surge because we had very limited testing data. If you remember from the first webinar, I talked a little bit about how testing data is akin to how we utilize GPS information to understand traffic, right? And so the more information you have as to where cases are, it helps you to really take actions to, avoid those areas where there might be outbreaks or high community prevalence, or figure out other mitigations that you can do. And one of the challenges that we saw, as we were coming out of the first surge here and looking across the US, is that because we didn't have good information on the relative risk of COVID during March and April, a lot of the same mitigation strategy was taken across the US. And that had to do with a lot of stay-at-home orders or recommendations. And during this time, I'd mentioned earlier some challenges, obviously, in being a parent during COVID. But my son's first birthday was on April 30th. And that's important to me because, like most folks right now, we hosted a Zoom birthday party for my son, and we actually were able to have a lot of family attend from different places that maybe wouldn't have been able to even attend in person if we weren't in the middle of a pandemic. But as I mentioned at the beginning of the first talk, I'm originally from the 8th most remote town in Kansas, Holcomb, Kansas. And so on this call, I had family from Kansas, from Colorado, from California, and everybody was talking a little bit about how their experience had been. And, we had a very acute experience here in Massachusetts. Obviously, I'd been working extensively on the manufacturing response. And I had really connected with a lot of folks in the health system that were being impacted by this in much more severe ways than myself. But there was also a time when we weren't just looking at how do we help meet the needs of supply for PPE, but also things like body bags. And so the experience that we had here on the East Coast in Boston, in New York, or other parts of the US that were hit really hard during the first wave were quite different from what I was hearing from family members in Kansas or elsewhere that were really wondering, like, is this a real thing? They maybe hadn't known anybody who had had it yet. And so that sort of relative risk aspect and those mitigation efforts really went, potentially might have been used a little bit early in some parts of the US because we didn't have good information. And so as this progressed, one of the things that I do want to show is, again, back to this kind of human connected problem, right? We started to very much experience this differently in some metropolitan areas or in coastal regions than elsewhere in the US. And so on the April 30th date, right, there were some cases in the middle of the US, but maybe not as many as we were seeing obviously here in New York and elsewhere. But it didn't take very long for COVID to find its way across the US. And as many of you have experienced, right, there was the first wave kind of in the coastal areas. The second wave over the summer was very much in the southern states and then in the Midwest. And as we headed into the fall, it was very clear that COVID was quite prevalent across the U.S. in many different cities, counties, et cetera. And we were finding that the transmission rates were very high, and we were looking at different ways of mitigating it. And so this information is really important to, again, think about from a system standpoint, right? How do you utilize information to maybe mitigate or put different mitigation levels in place? And one of the challenges, because we didn't have sort of these risk targets early on, is that there weren't really, targets for city, county, and state leaders to say, when we get to this level, here's the action we're going to take, right? So there was a lot of decisions that were happening, after you might pass certain levels because we didn't really know where we were at. And one of the other things that I'll say is that, this has been a learning experience for all folks involved. I mentioned one of the challenges was just the rate in which we were learning about how COVID was transmitted, how to treat COVID, the requirements for PPE, et cetera. And, it's not that COVID has the same risks to everyone in the US the same way, right? There's the probability of exposure that you might have from your community prevalence or maybe your job. But then there's the probability that exposure leads to infection and harm. And we've definitely seen that the severity of infection increases with things like age or other underlying health conditions. And so understanding the community prevalence really enables us to understand better and take actions of how to protect more vulnerable populations. And we've really struggled with that, I would say, not only here in Massachusetts, but across the US. But I think have taken more stringent actions as of late, or as this progressed in elder care facilities or other high-risk areas. Now, what I'm going to do is kind of introduce aspects of this sort of public health view. And one of the things that I'll mention here and kind of come back to is that there is a difference between testing as seen from a medical diagnosis versus how to utilize testing in a public health system. And I'll talk more about that. But for those of you that aren't familiar with PCR testing in terms of the process associated with it, I think many folks now have been tested for COVID, likely through a PCR test. But really the key primary steps, and this comes from an FDA slide, is that there is a specimen collection, right? That's when you first get maybe a swab. Early on, it was a nasopharyngeal swab. Now it's more likely an anterior nasal swab, and we've seen some utilization of saliva for sample collection. But then there's a series of steps that typically happen at the lab where you're going to be taking that specimen and you're going to be extracting the RNA, and then you're going to be amplifying it. And that amplification step is really what's going to enable you to understand what the viral load is that exists in that sample. The more you have to amplify something to actually get a signal, the less viral load that's there. And this is often reported as a CT value that you might hear talked about in the news, the number of cycles of amplification. And then ultimately what's important is that those results get reported. And how this fits into a public health system is really important because there's a lot of moving parts and there's a lot of interfaces, as we would talk about in systems engineering. And so when we first connected with the Harvard Global Health Institute and Center for Ethics, we were really looking at, their plan for pandemic resilience, but how can we look at this as a systems process and really understand what are the key functions that are involved? And then for those functions, what are some of the critical pieces of form to actually enable that function, and how do they fit together along the way? And so starting in the top left, where the sub-team from the MERT was coming with experience was really looking at maybe kitting and sourcing of things like swabs. And notice these bolded items are going to be verbs, kitting / sourcing, but looking at test swabs, viral transport media, what's the container that exists, workforce and training, procedures, etc. And some of that was coming from health systems that had implemented this within their own testing labs. Sample collecting, right, is a really key piece here. And is this going to be distributed, right? What's the location? Where's the site? But actually then what type of collection are you going to be doing? Is it going to be a swab? Is it going to be saliva, etc.? And then coupled with that are PPE needs. Following that is then if it is distributed sample collection, how do you transport? What's the transporting function for this? And then there's some logistical steps around how some of these labs automate tests, this idea of accessioning and data management that we'll come back to, but a lot of logistics potentially here. And then sample processing, this is those 2 steps that we looked at for RNA extraction and amplification. But what's the equipment for that, right? Is that something that's going to be available from different vendors? What's the workforce requirements, and so on and so forth. And there's a number of groups here in Massachusetts. Again, very fortunate here in Massachusetts that we have groups like the Broad Institute, who are really doing a tremendous job here of standing up a significant testing effort, as well as Ginkgo Bioworks, Beth Israel Deaconess Medical Center, and others throughout the state, either health systems or higher education. And then there's the important part of communicating the results, right? This is a public health system that requires the participation of the public, and how do you provide information back to those that are getting tested? But then how does that get integrated into the state's information systems? And then the sort of action-based steps that come out of a positive test result, right, then are the contact tracing efforts that the state stood up here with a group called Partners in Health, but then also the different health officials within cities and counties. And so again, what is the contact tracing workforce required? What are the training requirements for that, procedures, et cetera? And then coupled to that from an action standpoint are looking at, do we need to be doing disinfecting of certain environments if we find that there's an outbreak? We've been continuously learning more and more about the needs of disinfection and what are transmission rates through contact of surfaces versus airborne, et cetera. But then a really important piece to this is how do we provide support for isolation? And there's an economic component to that. But this is something that, if folks who if we think back to maybe the summer, folks who had been out of work or furloughed or laid off that are now getting back to work, if they're going to be participating in this public health system, right, but a positive result means that they may be out of work while they have to isolate, or if they've come into close contact with someone, how likely will they be to go get tested themselves? So we identified, this time period from sample collection to communicating results was really critical for the full system, right, to get information for contact tracing and then to help support isolation and really to break the chain of transmission. But how quickly could you also then get close contacts back into this testing cycle? And what we were looking to do is identify, groups that were doing this across the state, learning best practices, connecting them if they weren't maybe connected, but then also how do we communicate that out to other states and learn what other states are doing to share information and really look at how to understand what the needs are from a national level. So this MATC team had very much a foot in Massachusetts, but also a focus at the national level as well. So a simplified view of this, again, is really looking at those key functional aspects of the process and how that fits then across what Massachusetts were doing. But then tied to this, we talked about the risk metrics and looking at, the number of positive tests per 100,000 for cases, but also looking at numbers of tests conducted. Test result turnaround time is really, really critical, and I'll talk more about that. Positivity rate, and then number of contacts tested were some of the things that we were really looking for, not just the state, but other states to be reporting on to give a better visibility and information as to the prevalence of COVID and action steps that we could take based off of the level of risk. During this time in the summer months, there was a higher education working group in the state working on reopening plans that we were connected with, and really looking at how can we find funding to help support this? Because a lot of this testing, again, when we talk about the medical diagnostic testing, which is often reimbursed through insurance, public health surveillance or asymptomatic screening testing isn't something that is necessarily reimbursed through insurance. And so when we look at groups like higher education or here at MIT, it's not covered by insurance companies for testing. And so every single test is something that's being paid out of pocket by a university or another organization in this context. So when we look across the state, right, there's different levels of cases per 100,000 and how different states report that from a risk standpoint, right, different color modes. But one of the challenges that we identified here is that when we look back at this process, there's both a physical logistical chain of moving, materials and samples to labs, but there's very much a data piece right here and how you're reporting information and how that information is then being integrated at the municipal, county, state, and national level. And this is an area where there is a challenge with how lab data is managed and communicated through lab information management systems at different laboratories, and they're not necessarily designed and connected from a public health standpoint to be sharing the same information at the same time. So when we look here at the left, for COVID, a lot of manufacturers responded with new assays to help with testing, but they didn't all have a standard way in which the information or coding should exist. And then when you get to a lab, not all of this information is necessarily integrated or automated. And then how does that then get transferred to an electronic health record? And then how does this information then get escalated to municipal, state, or other national databases? And so that information flow is as critical as the physical sample flow. And so this organization that has actually been working on this called SHIELD, harmonizing the lab data and flow out of the CDC and FDA and some other groups, had started some pilots. And this was really pushed by a gentleman named Michael Waters, who unfortunately passed away in the early fall, but has really been looking at how do we pilot some interoperability of this data so that we can really get greater visibility and faster information flow through the entire lab system. Again, from that public health standpoint, because it's not just the individual that is interested in whether there's a positive or a negative result, but the public health system is really reliant on that to, again, understand in the context or analogy of thinking about where traffic is across a city view or something like that. And then from the actual physical flow side of things, one of the challenges is that a lot of these labs, again, operate kind of as an independent firm. And so part of what happened, and we saw this especially in the second surge in the Midwest, is that as we started having really high demands, labs that were processing tests from across the US started to have delays in turnaround time. And part of that is that they were very much pushing samples towards these labs, but they could only process so many at a time. And so an opportunity that we saw in trying to communicate out and really understanding that a poll-based system may be beneficial, so that these labs would only process as many tests as they could maybe get turnaround times in 24 or 48 hours. And so we really started to look at what is the PCR testing capacity across states, regions, and nationally, that we might be able to better leverage as opposed to just large national labs, et cetera. And so this is a concept dashboard. This isn't intended to be utilized. It doesn't have exact data behind it. But one of the challenges with turnaround time is that it's reported in very different ways. And if you think about from the time in which somebody gets their sample collected, right, that sample has a timestamp. And that result that you get, whether it's 24 hours, 48 hours, 7 days, potentially 2 weeks, right, is based on the time in which the sample was taken. And so it's really important to understand when the sample was taken as that initial timestamp and how long it took to get the result, because that tells you what time window you're looking at. And so it's really difficult to understand the time in which we're looking at in some of this reported information, because it could include results that are being reported from someone who had a sample taken yesterday, as well as someone who had one last week and 2 weeks ago. And so turnaround time isn't something that is just a standard number, it's really a distribution. And so some of what we were proposing is really looking at this from an operations, maybe more asset utilization perspective, and trying to help folks not think about just pushing samples continuously at the same labs, but maybe looking at what their total capacity is, setting some capacity utilization limits, and really driving the importance of turnaround time, because in this case, information is really important from a timing standpoint to make decisions to help further mitigate or adjust activities, both from an individual and a population's standpoint. So we were looking at testing capacity across commercial labs, health systems, right? Most health systems have their own capacity that maybe isn't fully utilized every day, depending on where things are at. Their state labs, academic labs, and other biotech companies, like I mentioned, Ginkgo Bioworks was standing up activities. And so really the turnaround time that we often see is sort of an amalgamation of all of this data coming together, which has different turnaround time distributions. Again, this was a mock-up dashboard for a way of looking at this, of understanding that we're not really looking at a single time period, and we see a lot of 7-day moving average type of results now. And with this information is, again, to think about not all areas are impacted the same way, in that we might have a general testing process, which we indicate here with the loop on the top, but then how do we deploy testing to look at hotspots? And so really thinking about that systems process, but having it in maybe 2 different forms of sort of a general testing process and then this hotspot testing process. And some pieces of that are going to be the same in terms of communicating results, contact tracing, et cetera. Another really critical aspect to this is looking at what efforts it takes for contact tracing. And so we were looking at some of the best practices that were identified here in Massachusetts and the investment that was made in Partners in Health and the number of contact tracers that they had deployed. But again, it's not something that is just as simple as you need a contact tracer and they can call people. It's a pretty intensive process that they've developed, and it really takes a team of contact tracers and managers. And so utilizing something like a sequence diagram to help visualize this to other states so that they understand, this is the sequence of activities that exists across the left. We have different aspects of form and who's involved across the top, and data and information management systems. And then how do those flow together, and where is there maybe a separation between the public health data and contact tracing information and who has access to that. And so as we continued to work through this, we put together a series of briefings, technical handbooks for folks to reference. And we started to really identify that there was a challenge of funding for this. And a lot of that had to do with the unorganized or lacking federal response. And so one of the things that was proposed is, how do we help states think about working together to pool together either their purchasing power or think about how to consolidate some of the operational aspects that they may be duplicating, right? To look at this maybe from a regional standpoint. And Danielle Allen, who again is from the Harvard Safra Center for Ethics, proposed this idea for interstate compacts, and that we, utilize for other things like interstate highways and et cetera. But how might we be able to use this as a mechanism to enable maybe bulk buying of tests or investment in testing capacity? And from this, there's actually a group of states, which includes Massachusetts, that did come together as an interstate compact, including Maryland, Louisiana, Michigan, Ohio, Virginia, and multiples others joined on afterwards to come together to buy some rapid antigen tests. And so we did see a number of states taking this up to look at ways in which they could collaborate together in really taking action against COVID. So the next part of this looking forward is really going to get into a discussion on the difference between, again, testing for a medical diagnosis versus testing for a public health system. And a lot of this is leveraged from work from many others, Dr. Michael Minna, and a number of initiatives that are going on here in the state that groups like Tufts University, the Broad Institute, Ginkgo Bioworks have been involved in, but really looking at what is a testing system potentially, where you might be utilizing multiple modalities to achieve a higher level outcome than just positive or negative. And so what's really important to think about here is the viral kinetics of what an infection looks like over time. And I come from a mechanical engineering background, but I spent a lot of time working on digital signal analysis for some of the medical device systems that I worked on. And so there's some analogies here that hold for digital signal analysis and understanding measurement techniques and what you're looking for, of whether you're just measuring a single instance of something, or if you're trying to identify events or state changes. And so what we see here, starting on the left, is likely when someone is first exposed to COVID, there is an incubation period. And this is something that we're getting more granular information on, but it does vary, but likely somewhere in the 3 to 5 day range, right? And it takes some time for the virus to take hold and multiply within an individual. And at some point, that individual moves from an incubation state to a transmissible state, or they're now infectious, right? So the viral load within the individual is high, and likely this is when, if somebody is experiencing symptoms, starts to experience those symptoms, and then they ultimately do start to recover. And there's a period when they become no longer infectious. And this is, again, not clear exactly how infectiousness correlates with concentration. But over time, this does deplete. Now, when we talk from a measurement standpoint, right, there's a lot of different ways in which we can measure the viral concentration or viral load in an individual. We've talked about the PCR testing, looking at RNA. Antigen tests are also an opportunity, as well as antibody tests as well. And so there's trade-offs between these, both in terms of types of samples that you need to collect, the types of equipment that you need, how long it takes, and how expensive it is. And so those are some of the things that, in a lot of the discussions around testing right now, is discussions around trade-offs. And one of those is also its sensitivity, and what viral load the test will look at and say, if you're above this line for a high sensitivity test, you're positive. If you're below it, you're negative. And that looks at, from a digital signals analysis, we might look at this as a positive rising edge on the front end and a negative falling edge on the back end. Now the challenge is, depending on whether or not you're using a test that has, in this case, identified as a high sensitivity, is again looking at that level of detection of viral load in an individual. The amount of time between states can be quite long, right? And so if we know that if we identify that an individual is going from an incubation state to an infectious state, right, the amount of time that it takes for that individual to then test negative with a lower sensitivity test is different than with a higher sensitivity test. And there's been instances where folks remain PCR positive for a very long time, although they're no longer infectious. So again, one of the challenges here is understanding what value we're trying to create with a testing system. Are we really only interested in, is an individual positive or negative, right? Are they above this line or below it? Are they above this line or below it? Or are we also interested in understanding not only are they positive or negative, but when did they become positive or negative? When did they transition states from incubation to infectious? And this is really critical from a standpoint in breaking the chain of transmission from a public health standpoint. So when we start to look at that chain of transmission, right, if we look at an initial patient who is exposed, in this case, they have symptoms, although for COVID, we've found that a large number of exposed individuals that are infected do not have symptoms, right? There's then that period of time where then now they're going to get tested and they get results, right? And so this turnaround time is really important to get this individual information so that they can understand that they need to isolate, right? But there's already been this period where they've been symptomatic and potentially are infectious. So when we start to look at that chain of transmission, right, they potentially infected another individual here, right, who feels, in this case, feels symptoms a little bit later and then is tested, right? There's, again, this delay time that exists. And we want to cut that delay time down as much as possible to a point in which we can identify, hey, this person was infectious here, they've exposed someone, you know, we've been able to isolate this individual before they expose someone else. And so we break that chain of transmission. And so testing is a way in which we can better utilize information to really look at not just as an individual infected and positive or negative, but again, when did they become infected? And again, thinking back to in ways in which digital signal analysis works is you have a measurement of something, but you also have the timing data, right? And typically you choose a certain sampling rate. And so viral load measurement in combination with timing data at a certain regimented sampling rate really gives us a visibility into infection state detection. And so when we look at this chart now here, each of these white dots indicates a point in which a test was taken, right? And so here, whether it's a low sensitivity test or a high sensitivity test, the result's negative. Same here, it's negative. In this case, that higher sensitivity test gives us a positive, right? But the individual may not be infectious yet. And then when we have the next test, right, both the lower sensitivity test and the higher sensitivity test are both positive, and then it trails off at the end. Now, in this particular sampling rate, you're looking at maybe testing every 4 or 5 days. And so that's a decision in which you can look at deploying and saying, if we're testing once a week, twice a week, 3 times a week, daily, right, what granularity do we need to really be able to determine when somebody goes from this infected and incubated state to infectious, because we really want to reduce the likelihood that someone infects someone else. And so this is something that's, again, a little bit difficult to translate into medical device regulatory context, because often a diagnostic test, its indication for use is identifying whether someone is positive or negative to some certain level of sensitivity specificity. However, how they are utilized in a public health situation and taking into consideration the sampling rate, right, using it multiple times from an asymptomatic screening standpoint or a surveillance standpoint is a little bit different. And we've seen actually these tests deployed in this way in higher education here in Massachusetts. MIT, Harvard, and UMass Amherst, Boston University, a lot of other higher education institutes have implemented testing regimens on campus in coordination with other mitigation and infection control activities. I think it's really important to highlight testing alone is not an answer, right? We need masking, physical distancing, et cetera, in combination with testing. But what we see here is many of these campuses were testing students twice a week, staff twice a week, and you see a very high volume of PCR testing in higher education in comparison to the broader population. But what we do see is a lot smaller number of cases, meaning that the test positivity rate within these college campuses was much, much lower than the broader population. And so this testing information and the speed at which the campuses were getting it was enabling them to complete that supported isolation action so that they could break the chain of transmission on their campus and keep as many students and staff from getting infected as possible. So a sub-community was basically carved out within the broader community, and testing was a really critical part of that. And so this is, again, thinking about the relative risk, not at the national, state, county level, but within a community, this is the campus environment versus the broader community environment. And so one way to look at this then is, right, this case was utilizing a sampling rate or frequency of testing with PCR to put together a testing system. Now, one of the ways in which we've been looking at this, as well as a lot of others, is how do you combine modalities together to maybe achieve this in a way that is maybe more cost effective or better utilizes turnaround time and resources. And so one way to look at this is understanding what are the key architectural decisions for a testing strategy or a regimen, and then what are the various options that exist along these key decisions. And so what we'll look at here is, from a strategy standpoint, am I going to be doing an individual test, two-stage hierarchical, meaning, one test, get some results, do a second test, potentially three-stage or some alternating. How are we going to manage data and logistics or traceability? And then from a population surveillance standpoint, this could be things like wastewater surveillance, but then what are those stage 1 modalities, stage 2 modalities, stage 3 modalities, et cetera. So when we look at that, primary modality is, again, could be PCR or rapid antigen, frequency, sample type, are we going to be pooling or not? And then how are we doing test processing? And then that just carries into each stage. So if we look at an example here, right, we're not going to pick a single column, but we're going to pick options across each row and build out, a testing concept or a testing strategy. So in this case, we're going to do two-stage hierarchical. Data is going to be lab managed. We're going to use an email for traceability. A lot of campuses are using student ID. In this case, we're not going to do wastewater surveillance, although that is an option. But we're going to do two-stage testing. And so looking at this, our first stage is going to be a PCR test. We're going to be doing this once per week. We're going to use an anterior nasal swab. And in this case, we're going to be doing pooling. So instead of doing an individual swab that gets processed, we're going to pool 16 swabs together. And this, again, is a decision that varies. You can do no pooling. You could do 4-to-1, 8-to-1. I've heard up to 20-to-1. But this is a way to quickly understand, are all 16 of these individuals negative? If it comes back positive, then how do you identify who that positive would be? And that is then utilized in the second stage. So if one of these pools of 16 comes back as positive, we're going to then utilize an antigen test to confirm who the positive is, right? We're going to use an anterior nasal swab. It's not pooled. And this is going to be point of use. So this could be done, again, one of the benefits of these antigen tests is that you might get results in as early as 15 minutes. And so total turnaround time on identifying an individual in a large population could be, potentially, say, 24 hours plus whatever time it takes for them to be identified through the rapid antigen. So within 24 to 48 hours. And this is actually the architecture that we are seeing deployed across Massachusetts this week for K through 12 testing. And so really looking at how do we create this, again, sub-community of schools within the broader community where we've already seen a lower transmission rate, lower prevalence of COVID, but in coordination with additional infection control activities such as mask wearing, hand washing, physical distancing, ventilation is a critical one for this, but then utilizing testing to help give us information or to isolate individuals as opposed to shutting down the entire school to really break the chain of transmission here from the community through the school or back out. And so this is something that is, again, here in Massachusetts, setting the standard for the nation as a way of meeting these goals of opening schools and getting our kids back to the classroom. Just lastly, what I'll end on here is looking then now as we look to incorporate vaccination rollout into this public health system. One of the challenges again that exists is how do we compare data? And so one of the important things is that with number of cases or number of tests, we've used a common denominator of per 100,000 population to look at this across the US. And so this is a recent data visualization that's on the Global Epidemics website, where we've been putting a lot of our information out to take a look at the vaccine rollout across states, again, at this common denominator of population, but then looking at this in context of the goal from the new administration of 100 million vaccinations in 100 days. Now, one of the challenges now is that we're really racing transmission of COVID and some of the new variants that have been identified as more transmissible while we're rolling out the vaccine from that sort of high risk population down. But we also want to ensure that for some of these vaccines, it's not just a single dose, it's both doses. And so there's a number of competing rates here that are really important. And so we're not going to be able to fully get through this just with the vaccine or just with testing. We need to remember that we need to continue to follow mitigation and infection control activities. So an analogy that I briefly touched on in the webinar that I think is really important to think about in the context of this public health crisis, right, is that there is no silver bullet. And for me, a lot of the individual decisions that we make while driving a car on the road are very similar to the decisions that we can make to participate in the public health system. And those individual decisions collectively make us safer. And we do this, almost on a daily basis while driving 2-ton machines at high speeds. And so this idea of thinking about this in terms of herd autonomy, right, or the point in which we're going to have enough autonomous vehicles on the road to keep everybody safe, right? It's a little while until we get there. So in the meantime, what we should continue to do is monitor GPS for traffic information and look for accidents, et cetera, right? Continue to be in traffic lanes, right? We already drive our cars in separate lanes to keep us safe. Don't go into an intersection if it's already full, even if the light is green. And then if you do happen to get in an accident, right, technologies in cars like crumple zones, airbags, and seatbelts help to keep us safe, or that will have less severe injuries if that does happen. Now, the analogy then holds for this public health system when we look at herd immunity, right? And vaccines are coming, but it's still going to take a little bit of time until we have enough of the population vaccinated to keep everybody safe. So in the meantime, we need to continue to participate in the testing system and look at that as infection information and avoid, high prevalence areas or understand where outbreaks are. Use that information to help in mitigating some of these sub-communities that we're setting up in higher education or K through 12. Continue with physical distancing, right? We do this in a car all the time. So if it's helpful for you to think that you're driving your vehicle while at the grocery store, that could be useful. And then avoiding, indoor and outdoor gatherings that are very dense, right? There's limitations on the number of individuals with inside restaurants and et cetera, and that's to help with this. And things like ventilation, PPE, face masks, respirators, et cetera, and hand washing have continued to shown to be effective in helping to reduce transmission. So we're going to need all of these things continuing to go forward until we get to a point where we have herd immunity. So as I mentioned at the end of the last webinar, this to me is very much a systems thinking challenge. It's very much a human connected problem, and there's still a lot of work left to do. There is no silver bullet. You know, we've been utilizing a lot of technologies for this, but we really need individuals and people to participate in this public health system. And for me, one of the really big positives from my experience is that there is a lot of power in cohesive collaboration and through systems leadership. And so I'm very optimistic about a lot of the relationships that I've developed through this last year. And, you know, looking forward to a time when we're past COVID and we can really exercise some of these relationships and opportunities, looking at, you know, as we go proactively to attack other challenges that we see in our community or elsewhere. So thank you, and I appreciate those of you that have logged on to catch this second part. Apologize I wasn't able to get to it during the first webinar, but please feel free to reach out with any questions, and thank you.